Hi, everyone. I'm Stanley Brown. I'm the Dean of the Dalla Lana School of Public Health, and I'd like to welcome all of you to this sort of mini symposium or seminar on COVID-19. Look, this is a time of pretty much unprecedented challenge in our healthcare system and our public health system. And before we say anything else, I just want to make sure that everyone knows that we're sending well wishes to everyone. We hope that you're healthy. We hope that you're following the guidance of public health wherever you are. If you want to join into the conversation online, please follow hashtag COVID-19 DLSPH. As we kind of go along through this, I just want to say a few quick things before I turn over to Professor Ross Upshur. So this has been a time of unprecedented change for the school. And I'm proud and I'm grateful of our community's flexibility, responsiveness, and adaptability. Some of the things that are happening now at the school would not have been possible even 4 or 5 weeks ago, or at least we never would have believed that they would have been possible, but we've had to respond to the challenge of COVID-19 in very different ways. Look, we're right now the largest and the most comprehensive public school in public health school in Canada. We're ranked among the top 10 regularly in the world, and we're surrounded by amazing researchers and clinicians, many of whom we're going to talk to you today, who've become important voices in public health this year around the COVID-19 pandemic. They're the same researchers and clinicians who are training our future public health leaders, and that's why we're here today. What I want to make sure, though, is that we're here today, too, to make sure that we're helping put more evidence and more information, really the core of effective public health out there for everyone right now. And with that, the only other job I have to do today is to introduce Professor Ross Upshur. Ross has been a leader in so many different fields. As we were just preparing for our discussion today, we were not only talking about COVID-19, we were talking about Ebola. You can see his recent paper in the New England Journal of Medicine, which I think came out in record time on some of the critical issues as we confront this pandemic. He's the Dalla Lana Chair in Clinical Public Health. He's the Division Head of Clinical Public Health. He's a practicing physician. He's had a long leadership career in a number of different areas. And he's also the school's resident philosopher, among many other different things. With that, I'll turn it over to Ross. Thanks, everyone, for being here today.
Thank you, Dean Brown. Good afternoon, everybody, and welcome to our symposium. I'm very privileged and honored to be the moderator for this. I want to echo Dean Brown's good wishes to everybody out there. I hope you're keeping well, keeping sane, being kind to each other, and of course, doing what you can to help bring this outbreak to a close. I'd also like to just thank all of the frontline public health practitioners and clinicians who are out there working. Many of them are alumni of the Dalla Lana School of Public Health, some of the public health leaders, to support them and give them our best wishes and hope everyone stays well. So today, as we've noticed, coronavirus is an unprecedented challenge to health systems. And one way that we can get ahead of the curve, so to speak, is to actually understand some of the dynamics, some of the epidemiology. And this actually focuses on two dimensions. And today we're going to look at some very, very innovative, cutting-edge research that students in the Dalla Lana School of Public Health are working on. So not only does it help us understand the dynamics of the pandemic, but helps us to respond. And it's looking at both the public health side of things and the clinical capacity side of things. And I'm the head of a division called Clinical Public Health, and the idea of how these two sectors work together is really germane to our response to COVID-19. So I'm really delighted today to introduce three scholars from the Dalla Lana School of Public Health. Our first speakers are going to be Isha and Jean-Paul Soucy. So Isha is a PhD candidate in epidemiology at the Dalla Lana School of Public Health and a fellow in the Emerging Leaders in Biosecurity Initiative at the Johns Hopkins Center for Health Security. Her research focuses on global infectious disease emergence using a One Health approach. And we might want to think a lot more about One Health as we consider this is yet the 6th or 7th major zoonotic outbreak that we faced collectively and globally. Specifically, her thesis is evaluating the transmission dynamics of influenza and avian influenza at the human-poultry interface in urban Bangladesh, which is critically important. The poultry industry and waterfowl are kind of the generators of more and more strains of influenza. She's supported by a Vanier Canada Graduate Scholarship, and her PhD research is jointly funded through the National Geographic Society and the International Development Research Centre. She holds an MSc in epidemiology from the London School of Hygiene and Tropical Medicine and a Bachelor of Science in Environmental Science from McGill University. So Jean-Paul is a second year PhD student in epidemiology in the Dalla School of Public Health at the University of Toronto. Now, he started his career in biology with a minor in mathematics at the University of Ottawa, and then did his MSc in epidemiology at McGill. His previous work includes studying the spread of Lyme disease in Ottawa and examining antimicrobial resistance in urinary tract infections in Quebec. His PhD thesis focuses on antimicrobial resistance and antibiotic stewardship under the supervision of Dr. David Fissman and Dr. Kevin Brown at the University of Toronto. I'll also introduce Dr. Nathan Stahl. Dr. Stahl is a clinician who received his medical degree from Western University and completed his residency in internal medicine and fellowship training in geriatric medicine at the University of Toronto. And as we all know how hard COVID hits older adults, his clinical expertise is going to be drawn on very shortly. I hope not too hard. He is currently a research fellow at Women's College Research Institute at Women's College Hospital and is completing his PhD in clinical epidemiology and healthcare research at the Institute of Health Policy Management and Evaluation here at the U of T. His doctoral research uses large administrative databases to study population health impact of caregiving for dementia. His other research interests include drug safety and older adults, sex and gender-based determinants of aging and healthcare utilization among persons with dementia. His research is supported by a University of Toronto Department of Medicine's Elliott Phillipson Clinician Scientist Training Program and is another Vanier Canada graduate scholar. He's a staff geriatrician at Sinai Health since 2017, and his clinical work is focusing on acute care geriatrics, and he works on the inpatient geriatric medicine consultation service and internal medicine clinical teaching units at Sinai Health. Now, what you're going to see is how these young scholars have used their experience in training and quantitative methods in clinical epidemiology and epidemiology to create tools that will help us understand the COVID outbreak. So I'm going to first turn it over to Isha and Jean-Paul to talk about their COVID-19 dashboard. So without further ado, over to the two of you. And
Great.
All right, thanks. Thank you so much for that introduction. We just want to give first a little bit of context and background. So the idea behind this this dashboard and this data set of tracking COVID cases in Canada, it all started about 2 weeks ago when Isha was just kind of working on this alone, seeing that there wasn't really a Canada-wide tracking effort going on for COVID. And then she asked me for help, and then we kind of figured, well, why don't we put this on a dashboard so that people can kind of understand what the present situation with COVID is. And so that's what led to the development of the dashboard, which I will share my screen now, and we'll look at that. Okay, so the overview of the dashboard is here. We start out on the top with just a number of reported cases so far. So this is just the cumulative total. The number of people who have confirmed who have recovered from the disease, the number of people who have died from the disease, as well as the total number of tests that have occurred for COVID. And this dashboard right now is really focused on getting a view of what the present situation is of COVID-19 as opposed to forecasting the future situation. So the second thing is just a figure here where we just have these numbers of reported cases broken down by province. So as you can see, we currently have the most number of reported cases in Quebec as of yesterday, but several other provinces have a lot of cases as well. And then we see down here, this is the cumulative reported cases curve. So we have here the curve for all of Canada. So this is the number of cases that have been reported to date. So this number never goes down because it's just the cumulative total number of cases. And we also see it broken down by province here. So we can see this red line here is Quebec. So Quebec had a very large increase in cases yesterday, about 400. And the reason for this is because Quebec decided to, instead of having to confirm every reported case in a hospital lab, they're now every case that was reported positive in hospital lab used to have to be confirmed in the provincial lab, but now they're just reporting those as positive. So because they changed the way they were reporting cases, that's why we see this massive jump in cases, as opposed to saying some underlying change in how the infection was actually happening. So sometimes when we see large or unexpected numbers like this, the reason is because it's a change in the way that we've been reporting those cases. And keep in mind that we should also expect cases to start going up in the coming weeks, just as we expand testing. And so we'll actually be able to catch more cases that have been actually contracted. So keep in mind that when we're looking at reported cases, what we're looking at is the number of infections that were acquired in the past week or two, because of course it takes about 5 days, maybe more, maybe less, to start showing symptoms once someone's actually contracted this disease. And then it takes a few more days from there for someone to be test positive and then actually be reported as a case. So the number of cases that are being reported today are very reflective of the infection, the patterns of infection that happened in the past week or two. So for example, if we put an intervention into place, such as physical distancing, which I'm sure you've all heard of, physical distancing or social distancing, then it will take about a week or two to actually be reflected in the number of cases that are reported. So down here, we have a summary table for the number of tests and deaths and recovered in each province. And if we want to see this in a more visual way, we can look at the case map. So here we see each of the health regions of Canada. So in Ontario, we call these health units. And we can see the number of cases that are in each health unit. So if we look at Ontario, obviously Toronto is going to be our biggest one. Sorry, that's Montreal. Toronto is going to be our biggest cluster of cases, which is not surprising since it's our largest health region. You may notice this large cluster up here. It's a bit out of place. Those are the ones where we were not able to find the information about which health region it was. So keep that in mind as well. We also have these controls on the side here, so we can kind of pick a certain province if we just want to focus on Ontario, for example. And we can also pick the time range that we're interested in. So right now we're showing the full time range, but we can roll it back to say last week, and we can see there's fewer cases. And then you can kind of roll that forward and see that the number of cases has increased. And you can play around with that if you're more interested in one province over another or one time period over another. We also have our cumulative reported case map, reported case curve. So this is similar to what we saw on the first page, but we also have a breakdown of the demographics of cases. Now, unfortunately, as of yet, we haven't received a lot of information on the demographics of the newly reported cases. So unfortunately, the demographics here, as you can see, we have 2,091 cases, but we only have demographic information on 394 of those cases. So unfortunately, these demographics are most representative of the early travel-related cases, but we hope that we will be able to get more data from the various provincial governments in the future in order to look more at the demographic breakdown of cases. And finally, our final tab here is a travel map. So you can see cases that are associated with international travel and where those cases have travel history when we have that information. So for example, we've seen a lot of cases that are associated with travel to the States. If you go early on, if we roll this back to the 1st of March, our travel cases are mainly associated with China, Iran, and Egypt. So those were our early cases. So that pretty much concludes what we have for the dashboard now. I'm just going to very briefly also show you that all the data that the dashboard is based on is completely public. So there's a link just at the side here to view that data. And if you'd like to look at the raw data yourself, you can do that and just download it from here. So I'll pass it over to Isha if she has any further comments.
Sure. So thank you so much. I am going to also share my screen so you can kind of see the data a little bit closer. So some of the variables that we're collecting are, case and provincial ID. These are unique identifiers, age, sex, health region, province, country, date of report. And as Jean-Paul mentioned, this is an important thing to consider, that this isn't necessarily the date of onset of symptoms or the date of infection. This is just when they're reported. And of course, there are lags in testing that we know about, and there's other lags generally that will be playing into this. And we also have report week. So for instance, if you want to look at things by week, travel history, the country of travel, and then if it's been reported as a close contact, I think something to keep in mind is that a lot of cases now are not, if we sort of scroll, this is the earlier cases, if we scroll to the bottom, we have a lot more blanks or not reported. So we're just really trying to keep up with what we can find. And most importantly, everything is curated from publicly available sources. So this includes local and government health authorities, as well as news reports. And you can see the news reports in every case source here. We also have a mortality tab, which goes into individual level information per death that is coming up. So if we're able to link these with a case, we have a case ID. However, a lot of things are not able to be linked because we don't actually know who that person was, in which case we just have them recorded. And then we also have recoveries as a time series, so by each province and each day, as well as testing as a time series. And this is just the cumulative number of tests. There are also changes in definitions that we've seen here. So for instance, Newfoundland used to report the total number of tests, and now they're reporting tests per person. And this means that we saw some of our testing numbers go down. I think in the beginning of any type of outbreak scenario, there are these type of changes and adaptations that are important to keep in mind. We have a code book here to hopefully give people a better idea of what everything is and what their description are. And I really wanted to highlight this amazing team of people involved. So altogether, we're known as the COVID-19 Canada Open Data Working Group. And this involves people from Guelph and at the University of Toronto, at Dalla, Lana, and generally around and about as well, who have really dedicated a lot of time and effort into curating all of this information. So, you know, it's a really big joint effort, and we're all trying our hardest to sort of make this as useful as possible. So that's sort of an overview of what we've been working on. So the data side for everyone that's really interested in downloading it and playing with it and getting a better idea of how things are emerging and changing. And then as well as the dashboard, which is really a public facing, and it is a very simple tool, but we're hopeful that, you know, this is aimed at the general public and people can look at this and get a good idea of a snapshot, a pan-Canadian snapshot, as well as a local snapshot. So I think that covers sort of our tool and what we're doing currently. And I'll pass it back to Ross to sort of go forward.
Thank you very much, Isha and Jean-Paul. A very beautiful presentation and a clearly useful tool. So I'm going to come back to you with some questions about how you think this tool might be helpful in understanding curve flattening and in responding. But first, I'm going to ask Nathan to present his tool, and then we'll open up for a general discussion. But thank you very much for your very clear and lucid presentation. Nathan?
Sure. Thanks very much, Dr. Upshur. Thanks very much for having me here today, and congratulations to Isha and JP on a phenomenal tool, which is useful to so many of us already across the country and beyond. So I'm going to just share my screen as well. So I'm actually going to start with this. So if anyone is interested in following along as I talk about the tool and play around with it, one can actually see the link here. So just as I'm talking here, you can see the link for our tool if you want to go on your computer and sort of play with the tool, because like Isha's and JP's tool, ours is interactive as well. So what our team wanted to look at was, from a healthcare system capacity perspective, what is the maximum daily number of new or incident COVID-19 cases a healthcare system could manage? And so I worked with an amazing team as well, and I have to acknowledge Vasily Gianakis, Deepit Bhatia, Matt Workington, and Dr. Isaac Bogosh, who we've been working like JP and Isha tirelessly on this in the last few days to get this tool launched. And the tool that we launched is an interactive one that models the capacity of acute and critical care resources during the pandemic. So this is a screenshot of our tool. Again, the link here is what you can go to as I'm talking to play around with it to see how it works. And I'm going to explain how, and I'll walk you through it. I'm going to explain how it works. I just want to give you a look under the hood to kind of see what goes into our tool. So the concept behind the tool is the tool determines what the maximum number of new COVID-19 cases could be that a healthcare system could manage overall. And it takes into account the rate of patients entering or being admitted to hospital. And some of those patients are going to get acute care. Some of them are going to get critical care. And unfortunately, some are going to require mechanical ventilation. So it takes into account the overall number of cases. And then based on an age distribution for case incidence and for case severity, it determines the proportion, an age stratified proportion of the individuals who are going to be consuming those acute care, critical care, and mechanical ventilation resources for COVID-19 patients specifically. Now, you can imagine when there are patients going into a hospital consuming those resources, on the other end, there are patients coming out. And so that is modeling the patient flow dynamics, where you're looking at the rate of people leaving the hospital who are COVID-19 patients and how long do they actually consume those resources for. So we have data, and I'll come to it, looking what is the expected or average length of stay for someone being in acute care, for someone being in an intensive care unit, or for someone being mechanically ventilated. So if you can figure out what is that number, the maximum number of cases where the rate of the patients being admitted to these facilities and consuming these resources equals a maximum daily turnover rate. So you can think about it like a bathtub. What's that number, which is the maximum number that an individual healthcare system could manage? And that's the concept of the tool. So to look at the sort of age-based case distribution and severity, we pulled data. So this is one of the reasons why we urgently need tools like JP and Isha are doing, is that there are many holes in terms of the data worldwide. So we pulled from the CDC last week what the age-based case distribution and severity is, and the links are in my Twitter feed, and certainly when I go to the tool, I will show you as well that the links are there where we pulled all the data from. But they published data on, you can see age by age group, what of the existing cases, how many have been hospitalized, how many have had ICU admission, and then what the case fatality rate is. So we use data for this on the age-based case distribution for hospitalization and ICU admission. And we know from data from the Chinese that about 50% of people who are ending up in critical care were being ventilated. We probably think that number is actually likely going to be a little bit higher in North American settings, but it gives you an idea of the age-based case severity. Then we also looked at, okay, so you have these resources. This is the proportion of people going in that are going to be using these resources who have COVID-19. What's the expected length of use for this resource utilization? So again, we're relying on the rapidly evolving data, but what we did find here is that we looked at the average length of acute and critical care resource utilization, and we have some of the data, again, pulled mainly from Asia, which was obviously hit earlier in this pandemic. So we are just starting to describe what the clinical course is in North America. They found that the length of stay in their acute care wards is about 11 days. What's interesting is there's quite a variation in terms of the length of utilization for ICU stay and the time that someone's mechanically ventilated. And the range seems to be somewhere between 8 to 20 days that someone's spending. So you can imagine if a huge influx of patients are coming in with COVID-19, and they're consuming this amount of resources for this many days, this is going to place strain on healthcare systems. And we're already seeing that in places like Northern Italy. So the last thing that we do then as a healthcare system, and again, I'll walk you through with my tool, is an individual healthcare system. So the nice thing about this is that it's modifiable to local clinical experience and context. So the healthcare system can actually look and say, okay, I have this many acute care beds in my hospital, in my healthcare system, or you can look at it in regions. And so this actually, the defaults we put in here for the purposes of today's webinar are Ontario data. So there's there's approximately 33,511 beds in Ontario, but you can imagine the healthcare system is not only accommodating patients with COVID-19, there's all the other conditions that people continue to have and experience and need to be hospitalized for. So we say, okay, what is the percent of acute care beds that could be sort of maximally available for COVID-19 cases? So if your healthcare system generally runs, and we know this in Ontario for acute care beds, actually probably runs quite high at about close to 90% at all times, certainly at my facility. But we're seeing things in terms of redistributing patients and making room for this. So if you estimate that maybe 75% of these resources in a healthcare system are available for COVID-19 cases, you take that into account. So obviously it's not the entire number, 33,000, it's the 25% of that that's going to be available, the other 75% being for all the other patients. And then many healthcare facilities are looking at how can we surge capacity within our healthcare systems to make additional resources exist that we wouldn't normally have when we're functioning at times outside of a pandemic. So as a demonstration, and again, I'll come back to the online tool, which is interactive, we calculated what it would be the maximum daily number of new cases a day, and JP and Isha are contributing to reporting that data on a daily basis along with their team. What is the maximum daily number of cases that could be managed by the Ontario healthcare system? So if you look here, if there are the maximum numbers based upon the age-based case distribution, and the expected proportion of those individuals who are then going to be admitted to acute care, be admitted to critical care, or be mechanically ventilated, what the tool estimates is that the Ontario healthcare system, the acute care beds could accommodate a maximum of about 2,848 new cases a day. But when we start to look at critical care and mechanical ventilation, the healthcare system for acute care beds can accommodate about 300 cases a day, new cases a day, and about 376 new cases a day for mechanical ventilation. So if you look at yesterday's data, we're waiting for today's, there are about 78 new cases in the province alone. So, as we see the curves go up, we're going to approach that threshold, which represents that sort of maximal state where the healthcare system is able to manage the patients based on the patients coming into the system with COVID-19 and the expected rate of them going out. So I'm just going to flip over here to the tool. So if you actually go, and this is again the link that people can access for the tool, but if you load up the tool, it's just going to take a second to reboot here. I just got it, just reloading the tool. What can happen here is that individuals can take the number of beds that they put in. So I'm just showing you in the gray while this loads up. Sorry about that. The tool can take into account the expected resource utilization. So sorry about that. Maybe many people are on the system and it's hard to visualize, but the expected resource utilization, and we can come back to this. So it looks at the mean days in acute care, the mean days in critical care, and the mean days that one would expect on a mechanical ventilator. Let me just put this into a different window here for you. Oh, sorry, it's showing me the Sinai system. That's big. So while that loads up, then, and I will come back to this, Ross, if you give me a moment after so that I can play around with it for people. If you look at the number of acute care beds, you can actually calculate that proportion of acute care beds that would be available for COVID-19 patients. You can calculate the proportion of critical care beds that would be available for COVID-19 patients, and you can calculate the proportion of patients requiring a mechanical ventilator. And then based on that, and again, healthcare systems can adjust, they will spit out that number that's specific to your healthcare region, both based on the demographics and based on resource availability of that maximum number of cases that you could accommodate a day, which is what we pulled for the Ontario data. So with that, I'm going to hand it back over to Ross. I'll try and reboot this up so I can walk people through the tool in just a moment.
Thank you, Nathan. So this has been incredibly illuminating. So we have two complementary tools. One that's taking perspective from the community and the public health side, and one that's kind of going to take what's happening on the community side and feed it into a health system. Now, we all know that we're being asked to practice physical distancing. Remember, we were calling it social distancing, but it's more accurately physical distance, because we do know that isolation is a risk factor for health and well-being. So think of physical distancing and social connectedness. There's been a lot of talk about flattening the curve, and we're being asked to make extraordinary sacrifices from our usual day-to-day activities. Schools are closed, bars and restaurants are closed, the Olympics are postponed. So everybody is making sacrifices. Isha and Jean-Paul, can you explain the principles of flattening the curve and why this might be important? And then I'll turn to Nathan to ask him about what will happen if we are not able to flatten the curve in terms of the demands on the health system. Isha or Jean-Paul, whoever wants to speak to this point.
If I can just, first of all, just link up what we're talking about, flattening the curve, and kind of link up what Nathan was talking about to what we're showing in our tools. So if I just share my screen again, here's a fairly common illustration of flattening the curve. So this is exactly what Nathan was talking about. So this is, the number of cases over time. So here in scenario 1, we have cases happening, just exploding and just happening kind of all at once. Whereas in the second, the blue case here, we have the cases kind of growing more slowly and being kind of spread out over a longer period of time. This is what Nathan was talking about with the capacity of acute care, of ICU beds, of ventilators and such. Basically, if we have an explosion of cases all at once, then we overwhelm that capacity. But if we can spread it out over time, so flattening this curve of new cases, then we can actually manage to have patients come in and then patients be discharged and not run out of ICU beds. So if we look at here, so this is the number of new infections per day in Canada. What we want to see is this curve here that shows the number of new cases. We want it to be kind of longer and shorter. Shorter as in not going having a lower number of new cases per day, but wider as in it's spread out over a longer period of time, as opposed to being skinny, so spread out over a short period of time, but very tall, so all the cases at once, because that will overwhelm the healthcare system. Isha, do you want to explain how?
Yeah, and I'll share my screen as well, so you can kind of get that idea and give a little bit more detail on that. So we can kind of see here that exactly what Jean-Paul just said. We kind of want to see this curve longer and sort of shorter than tall and spiky. But it is important to realize, again, when we talk about this idea of flattening the curve, what we're seeing is what's happening today is probably a reflection of what happened of cases acquired over the last 1 or 2 weeks, given the reporting delays, given the lag time and the incubation period of the disease, and just the time between people show symptoms and present to hospital as well, or their primary care physician. So really, it sounds like we've sort of really enacted social distancing, or physical distancing as we like to call it now, about a week ago. So hopefully what we would see is that in a week or so from now, or about 2 weeks from now, that these cases would keep going a little bit more flat, and they wouldn't sort of keep spiking up. Again, just to reiterate, this large jump is a change in case definition, or a change in reporting method. Not change in case definition, my apologies, but a change in reporting method. But overall, what we hope is that we keep seeing a steady, longer curve as opposed to a high and spiky curve, which can really give you an idea of what it means to implement and see the effects of things like physical distancing. And that's really what we mean by flattening the curve, which I think is a strong Twitter hashtag at the moment. So I'll turn it back to Ross, and I hope that answers people's questions or gives you an idea of what it means to flatten the curve and what that actually looks like in terms of data and in terms of visualization.
Thank you.
And if I can just add
go
one
ahead,
more
JP.
thing,
Yeah, please do.
Yeah, so when it comes to flattening the curve and this idea of hospital capacity, it's not just ventilators and ICU beds and things like this for people with COVID. If you have an overwhelmed hospital system, then people who come in for other reasons are also going to get less care and have less chance of survival. So if you have, car accidents, things like that, and you have a totally overwhelmed hospital, then those people are going to have a worse shot of getting out of there in one piece than if we had not had an overwhelmed healthcare system. Same thing with heart attacks and all sorts of other reasons why people need intensive care in hospitals. So it's important that we're not just talking about people with COVID, we're also talking about just everyone who needs medical care in the country.
Yes, absolutely. We have to be attendant to the unintended consequences and what we called during SARS, which I was working in, the collateral damage from other sources. Nathan, I understand you're ready to roll with your tool. And if you want to also give some commentary on what you think the healthcare system response would be and what sort of planning is being done within your institution and organization and how the geriatric community is getting prepared for this.
Sure, absolutely. So let me come back to this now. So, the analogy of flattening the curve sort of happened with our tool here, where so many users surged it that it got overwhelmed when I was trying to explain it to you. So I think you've all flattened the curve who are watching remotely, and I can now enter it. So just to, as I'll walk you through this tool. So again, these are based on data from emerging publications that are happening, most of the data coming out from China. So these are where you can play with the number of days that one is expected to be in acute care for COVID-19. And as we progress through this pandemic, this may change. So one could change from 10, one could change the curve from 20 to 10 and see how that results in changes to the maximum number of days that someone could, or the maximum cases that could be accommodated in acute and critical care resources. Now, as JP was alluding to here, these numbers are actually set for Ontario. And the numbers you're seeing here is not the actual overall number of beds in Ontario, it's the number of beds that could be maximally available to support COVID-19 patients. So if you actually click on this, here's where we say, okay, there is 3,511 beds, acute care beds approximately in the province of Ontario. And we say about 25% of those beds are currently being used or are available for or currently being used by COVID patients. So if you say, well, that's actually not reflective of my healthcare system. Actually, at most times, only 10% of the beds are available. But I can add to the province another 500 acute care beds. You can actually change that, and you can see how this results in changes to the maximum number of beds that one can accommodate at a healthcare system level. The other thing is here that these numbers are for the province of Ontario. So obviously someone at their individual hospital could input the total number of acute care beds and play around with these tools to be able to sort of estimate what that threshold is that they're going to be able to accommodate. The same with the rates of mechanical ventilation. So in other jurisdictions, and you'll see as I pull this bar up, more and more patients need mechanical ventilation. And I would argue that the rate of 15% of mechanical ventilation in the ICU is probably lower than we're going to see. This pushes down the number of new cases of COVID-19 we could have in a healthcare system to be able to accommodate all the need for mechanical ventilation. And then finally, if you're in a jurisdiction, and then we've seen this in northern Italy, where your population, the case distribution of your population might be overly saturated with patients who are the age of 65, 75, and 85, the case distribution of your population, if you change that as well, that's going to have implications on the maximum daily number of cases that would be manageable for the healthcare system. So that's how one can play around with this tool. And we hope it can be helpful because while some of the assumptions are there for people based on the best data and literature we have, it's modifiable to the local experience, which is essential during this times. And some of the reasons why we're seeing such differences in outcomes and utilization between jurisdictions like Italy and jurisdictions like China, which have had differing rates of incidence of cases based on age distribution and also severity of cases as well. So that's our tool. Now, to come back to what Ross was talking about in terms of how our healthcare systems like my own planning, these are some of the things and the conversations that are going on. We're hopeful that a tool like this and access to timely data like Isha's and JP's tool can have are going to assist health system capacity planners. So Dr. Tedros, the head of the WHO, said, I think it was yesterday, the day before, you can't fight a forest fire if you're going in blinded or blindfolded. And that's certainly the case here. We need good access to data, not only about the cases that are going on in our regions, but access to the resources that are going to be available so that we can plan before we're entirely overwhelmed. So I think, a lot of, and I think in the healthcare community and also in the scientific community, we really appreciate the support and well wishes and words that are the groundswell of sort of support for us as a community. I think what one of the misunderstandings might be is that right now we actually haven't had the big bulge of cases that we're anticipating, and a lot of the work that's happening right now is doing this kind of planning. How can we surge our capacity of critical care beds? Where are we on this curve in terms of the cases? Who can we redeploy from this service to that? How can we convert less acute services to be virtual where possible? These are the sort of difficult decisions that healthcare policy makers and planners at local and at provincial levels are trying to make right now, and they're critically important because at the extreme of this, we've seen things like Northern Italy, and we've seen things like even in Washington State, where decisions are needing to be made in terms of allocation of resources. And Dr. Upshur actually had a paper in the New England Journal of Medicine yesterday that touches on what some of the rationale are going to be if we do exceed that capacity to be able to allocate resources. So this is a lot of what's going on right now on the front lines before this bulge comes in, where I think everyone's anticipating being involved in sort of frontline clinical care.
Thank you, Nathan. So it strikes me that we've had advanced warning. We're now using the best of our capacity and some of the brightest young minds in our country to create tools that will actually help us make evidence-informed decisions, while at the same time we're developing capacity and evaluating therapeutics, while we're very much involved in vaccine development, because I think one of the other issues on that whole curve flattening, there's another approach that sort of says you're going to buy time to wait for the cavalry. We haven't asked you to speculate on how you see the future going, because neither of your tools are forecasting tools. But I do note with the cumulative cases, we're sort of starting to see a bit of an exponential rise across Canada. So I'm just wondering if you would have any thoughts about where you expect this epidemic to go. Will we see continued rise in the provinces? And hopefully we'll be able to see, I think one of the cautions, and maybe Isha and Jean-Paul and Nathan, you can reflect upon this before we open up for questions, is not to get too worried if we see things going up initially, because it's going to take some time for those social distance or physical distancing countermeasures to take effect. Would you like to speak to that? And then we'll open up for questions.
Well, I think it's a great, oh, sorry.
No,
well, yeah, I think it's a great point that, it is going to take time for these measures we put in place to be reflected. I think it's also, we have to keep in mind that as testing ramps up, as provinces clear their testing backlogs, we're going to see those numbers tick up quite a lot. And that shouldn't necessarily be alarming, because it's better that we know about those cases than those cases being undetected, right? So we should expect, as testing scales up, that we would be seeing fairly large increases in the number of cases. But I don't know if you have anything to add to that, Isha.
Yeah, and I think that's a great point, that nothing that we're currently doing is reflecting, it's not projecting forward. That is something on our radar. We're both working in mathematical modeling as well. So tools like mathematical modeling can really help researchers. So this data can be fed into those type of tools to estimate and project potential numbers of cases without interventions and using different intervention scenarios, and take into account how things, can change in, a lot of what we're using right now is data coming from other places, and we know that like the natural history of diseases are tend to be very similar, but they can act very different ways, and they can have very different playouts in different countries. So that is something that we're going to be working on as well, and using this to try and help better equip the Canadian leaders to make informed decisions on interventions and projecting forward as well.
So I think it would be fair to say that if we see this continued upswing over the next couple of weeks, that this would be expected and anticipated, and no cause for despair, and no reason for us to lose our resolve in employing the countermeasures that are in place. That it's going to take a little bit of time and patience because there's a certain momentum already happening in the community. Would that be a fair estimation?
Definitely.
Yeah, but I think it emphasizes that we have to act now. And we have
Yes,
to
the
be
time is
acting
now.
right
Absolutely.
Yeah.
So we have several questions coming in. I'm going to put the first one to Nathan. Is it possible to enter a population estimate for smaller, more local catchment area populations? So this could be used for a hospital.
Absolutely. So that's the goal of the tool. And I actually think it's when you think about a tool that if you're applying this to all of Ontario, there are undoubtedly going to be regional variations in both the incidence of cases, but also within the availability of resources. So yes, as long as you can either use the default inputs, but you can also put the local clinical context into there. So if you're seeing that in your clinical context, the length of stay for a COVID-19 patient is actually exceeding what other centers are doing, you can put that in. As long as you know the resource availability within your hospital in terms of the number of acute care beds, the number of critical care beds, and the number of ventilators, and what your usual use is and the ability to surge, you can absolutely make predictions at an institutional level.
And one of the virtues I see in your tool is that those parameters are modifiable according to emerging data. So they're not fixed in stone, it's dynamic and it's interactive and it's responding to the best knowledge that we have at any given point in time. And I think the nimbleness, and I think the same is true of both Isha and JP's tool, the nimbleness actually allows us to get almost close to that long cherished dream of real-time data response. Isha and Jean-Paul, we have a question for you. Does your tool provide detail about the number of cases in a specific region or city, for example, North York, Mississauga, or Brampton?
So actually, you can sort of filter this to the provincial level and then start looking at things on the map at a closer level. Right now, we don't have a feature that allows you to look at cases visually per health region. One of the reasons for this is really that a lot of cases now that are coming in have very little data reported. So we just know that they're in Ontario. We don't really have a lot of information on health region or age or sex or any of that. So that information, hopefully we'll be able to look backwards and look at public health units, local public health units to help fill that information in. But the data itself is also freely available and, downloadable and easily accessible. So if that's something that you're interested in, looking at your personal and local region, all of that data is there, with the caveat that there is a lot of missingness, especially in the case of Ontario for health regions. So keeping that in mind when you're interpreting the data.
Great.
Yeah, so really, really early on in the outbreak, we were getting a lot more information on each case. So in many cases, we would actually get the specific city. But now it's pretty much, we either get the health unit, if we're talking about Ontario, or sometimes we don't even get that.
So I have a question. So another question is, so why the total number of cases so when you're flattening the curve, if you look at the kind of characteristic curves that have been sent around, it looks like the area under the curve is the same. You're just flattening it. So it seems to connote that there's no reduction in the number of cases. So the question is, does decreasing transmission not have an effect on the overall number of cases over time?
Well, it certainly should. I mean, the graphics that are getting passed around, I think, we're not necessarily prepared for mathematical accuracy, but they're rather just kind of
now is your time to correct the record.
Yeah, so certainly we would hope to see a reduction in the total number of cases, as well as the total number at any particular time. But I think the real focus right now is just to slow down the rate, because if we hit that limit of the healthcare system, the consequences could be very dire. But if we do have enough ICU capacity for everyone, then we would see, for example, a lot less severe complications and deaths from COVID than if those cases are spread out over time. So the seriousness of each individual case is reduced on average if we spread it out over time, rather than if we have them all at once. So it's important to keep that in mind. But yes, we would certainly expect measures such as physical distancing and stuff to reduce the overall number of cases. But of course, it depends on, for example, how long those are in place. It also depends on what happens with the season. So there's some reason to believe that warmer temperatures help to reduce the spread. They certainly don't stop it, because we see it in spreading in warm countries, but it may help reduce the spread. So there's a lot of factors that kind of play into this. But I think the key thing to remember is, even if we do end up with the same total number of cases over time, the fact that we could avoid it, if we can avoid it from overwhelming the healthcare system, the consequences of those cases will be much less severe.
Isha or Nathan, do you want to add to that? Because we've got two more good questions and I think about 5-10 minutes left.
No, why don't we move on to the next one?
Okay, so I'm going to ask I'm going to modify one of the questions. So the question is, are there plans to add data on comorbidities to the hospitalization and mortality numbers on the dashboard? One of my so I've been a multimorbidity researcher for the past 15 years, and one of the things I think that we didn't anticipate coming out of the China data is that the population and demographic distribution in Italy is very different from China, which has a younger population. Multimorbidity is the rule, not the exception in North American and European populations. So we would expect there to, and I think multimorbidity and coronavirus are not good bedmates. So is there any thoughts of adding comorbidity data to the tools?
Yeah, so I can talk about it for ours. So we have been trying to collect that information. Again, just to reiterate, all of our data is from publicly available sources. So it's what's being reported by governments, it's what's being reported by the news media, and these factors are just not really being reported at the moment. So this is sort of our limitation in being able to present that. Of course, we recognize it is important, and the age structures of different countries have a huge impact on how we'll see transmission dynamics play out and affect the population as a whole. But again, so we don't really have a good idea of a good source for comorbidities to be able to add that to our dashboard. We do have an intention to add a mortality tab. As you may have seen in our data set, we are collecting individual level information on mortality and trying to link this to the case level data where it's available. So that should be coming soon, and hopefully is in our pipeline. But in terms of our limitations, we're hoping that more robust data will become available, and then when we get access to that, we'll make sure everyone else does as well.
I think you're muted, Ross.
Nathan, do you want to add to that? Sorry.
Yeah, so from the perspective of healthcare sort of capacity, at the crudest level, comorbidity is only going to contribute to more acute care utilization, and is only going to contribute more hospitalization, more ICU admissions, and more need for mechanical ventilation. And so, yes, we could put in things about comorbidities and mortality, but our tool is actually just monitoring patient flow dynamics. So we actually take into account mortality, because when you're looking at the average length of stay is determined by someone either being discharged or determined by someone dying. So that putting in mortality into our tool is not necessary in the same way, because it already actually accounts for that in terms of the patient flow dynamics and the turnover.
And we can actually, we can actually model comorbidity by looking at existing data on levels of comorbidity in the population. So some of Walter Wadchus and Laura Rosella's work would be helpful here. So I think we have time for one last question, and it'll be directed to Nathan. So there's the idea here is that the tool that you have talks about beds and ventilators, but how are we going to think about modeling the human health resources and the staffing of these beds? Is there any thoughts of a tool that's going to help with that question?
Yeah, hugely important question. So, you know, the challenge, so yes, all of these tools can be sort of souped up and take into account multiple levels of resources that contribute to a functioning healthcare system. The challenge with human health resources is that they are so variable on an hour-to-hour to day-to-day basis, particularly in the context of COVID-19, right? So we are seeing, and we've seen this in other jurisdictions, healthcare workers becoming sick. We don't know the exact proportion of that, but some proportion of our healthcare workers are going to be not available to work for a 14-day period if they get COVID. Some are taking themselves out of the workforce altogether in terms of frontline clinical care for acute care, critical care, because they may have underlying conditions that pose them to be at higher risk or other reasons. And then, you know, we're also, so those people are leaving, but we're also thinking about bringing people in different ways. So Italy actually advanced all fourth-year medical students to get them to contribute. Places like British Columbia are looking at bringing back retired physicians. So I think that would be a very complex thing to model, but it is the sort of same concept of human resources in and resources out. And I think it's an interesting question. Whether it can integrate with this existing tool, that's something we'd have to think about. But we sort of looked more at sort of the physical resources in a healthcare system, but I think there certainly is an opportunity to develop a human health resource tool like that.
Great, thanks. So one last question before I thank you and close. People are asking, how can they contribute to your work, and how can they contribute to the COVID work in Canada? Any thoughts on that?
Sure, I can speak to ours. So we're rapidly growing capacity, and you know, are really grateful for all of the volunteers who are supporting our data curation and data entry. And so if you're interested, you can let us know. We are slowly onboarding people just to ensure that the standardization of data is you know, accurate and complete. But I think at a personal level, especially for people that work in public health or epidemiology, this can feel really sort of, there's, you know, you have a skill set and you want to contribute. And this is sort of how a lot of these projects, I think, emerged in the first place. Jean-Paul and I were in that same boat. And I'm sure Nathan, I mean, he's already on the front line. So, but, you know, there is this capacity. And I think if you're interested and you have ideas, reach out to people and, you know, reach out to us, reach out to others, talk to people and see what they want and see what's useful. And at the individual level, I think something really important is just to keep checking in on your family, keep checking in on, you know, other people, your neighbors and things like that, just trying to be a good social citizen and support system for the community generally as we're going through things that are changing.
Great. Nathan?
Yeah, absolutely. So I would echo Isha's thoughts more generally. I would say for our tool, I actually didn't know DPIT or Matthew before this tool. So actually our tool was sort of born out of crowdsourcing, right? So there's a lot of people, you know, we said we need someone who can contribute this skill set and that skill set. And I think this speaks to the scientific community coming together and coming together quickly to produce tools like this. So yes, there are ways to contribute. I would say that for people who are interested, there's ways to contribute scientifically. And you know, this isn't the only work we're involved in terms of science. So reach out to people. Don't be shy about that. I would say that people are very overwhelmed right now. So don't be offended if you don't get a response immediately. But certainly we are looking for smart people. And I don't want to speak too broadly, but I think most people are looking for smart, motivated, interesting people, because this is a huge problem. And the scientific community has really sort of come together and stepped up to see how can we contribute new knowledge to both advise our healthcare system and to hopefully help patients. And so absolutely reach out to people. And then again, to echo what Isha says, I think as part of a larger sort of public health community, I would say that we have a role to model sort of what good social behavior and what being a good citizen is like in terms of social distancing, working from home, reaching out to support those who may need things at this time. So I can speak from the medical school level. All the medical students who have been redeployed actually offered quite incredibly, and are doing this now, to provide childcare to frontline healthcare workers. So there's a lot of ways, not just scientifically, to support the community, which is quite remarkable, and I think has shown a lot of the best of what makes us Canadians as part of the public health community.
Thanks, Nick. JP, do you want to say a word before I close things off?
No, I guess just echo what everyone else has said. Just, remember we're all in this together, and let's respect social distancing, and we would appreciate the contribution to our tool and to other tools and ideas if anyone has them. So yeah.
Great. Well, first I'd like to thank Nathan, Isha, and Jean-Paul for exceedingly lucid presentations, and also for their ability to turn, I mean, this isn't what they were working on, but to take their intelligence and their training and devote it to producing what I think are two incredibly insightful and useful tools. It makes me very proud as an educator to see this, so I'm very proud of your work, and thank you very much. I'd also like to thank everybody for attending today. Please send us comments as to whether you think this was useful and worthwhile. I know many people have competing demands on their time. If you have ideas for future webinars, I would like to see this become a regular part of our community. And finally, I do want to wish you all well, keep sane, be kind, wash your hands, practice physical distancing. We can prevail over this virus. It's going to take some sacrifice and resolve, but as we've seen from the tools, it's possible for us to make a difference and to end this outbreak. So everybody have a good day. Thank you for your time and attention, and hopefully we'll be coming to you from a webinar at Zoom soon. Goodbye.
Thanks so much. Bye.
Thanks. Bye-bye.
Thank you, everyone.